Okay.
Okay, guys. I'm going to talk about neuropathic pain. I'm sure you're all awake still. So, mysterious signs of pain. Now, this was my situation when I was at your level, maybe the intermediate trainee or earlier than that. So I couldn't understand anything about pain, and it still partially understands how pain works.
Has your situation changed now?
So this is the pathway. So the four things we need to remember as a junior trainee is the pathway is transduction, transmission, modulation, and perception. So transduction is when the pain travels from periphery to through the receptors or nociceptors to the spinal cord. When it's perceived, so that's transduction. When the pain is actually converted to a signal. Transmission is when it's carried by those receptors to the spinal cord. Modulation, all the modulation happens mostly in the spinal cord. That is changing, either it heightens, the pain is heightened, or it's reduced, or whatever happens. That's all in the spinal cord. And then perception. Perception is, as Mahesh said, perception is in the brain. It's also in other parts of the brain apart from somatosensory cortex, which is prefrontal cortex, and anterior cingulate gyrus, which is emotional, and the emotional affective component, and the nociceptive component. So both are perceived in the brain. So there are a few definitions that might help you in the exam. So neuralgia, pain distribution of nerve or nerves, neuritis, inflammation of nerve or nerves, a neuropathic pain. So this is an important definition. It's pain caused by disease or lesion of somatosensory nervous system. And I've mentioned lesion, what is lesion and what is disease, and how we differentiate that. What do you mean by lesion and disease in this definition? Now, neuropathic pain is not just one thing. There are a lot of things. So you can get a combination of all the things. So central neuropathic pain, and then there's peripheral neuropathic pain. There are other confusing terms like radicular pain, radiculopathy, which I will explain if you want to know about it. Central neuropathic is the lesion or disease of the central somatosensory nervous system. Peripheral is a similar lesion or disease of peripheral somatosensory nervous system. And neuropathy is a functional or pathological change in the nerve, which can be one nerve or multiple nerves. These are again important definitions, which is all mentioned in IASP website. You can go and have a look. Mahesh pointed out a few things, and we've been pointing out it's allodynia, analgesia, anesthesia dolorosa, which is pain in the region which is anesthetic. Dysesthesia and anesthesia dolorosa is very common in patients with post-herpetic neuralgia. Dysesthesia is an unpleasant abnormal sensation which can be spontaneous or evoked. Hyperalgesia, hyperesthesia, and hyperpathia, which is like an abnormal syndrome where the threshold is increased, but when you cross the threshold, the stimulation is horrible. Again, this is the same. This is more related to neuropathic pain, where tells you how different things happen in the periphery, dorsal root ganglia, spinal cord, and the brain. Now, the important thing to remember in neuropathic pain is that it's slightly different from nociceptive pain because there are many theories with it, attached to it. So the theories are that there is increased nociceptive sensitivity, there is ectopic firing, and altered signal transmission. In the dorsal root ganglia, there is increased excitability, altered gene expression, and again ectopic firing. At the level of spinal cord, I'm sure you guys know about rex lamina. So there are 10 areas in the spinal cord. So a spinal cord is divided into 10 areas, which are rex lamina. And different fibers, they go and they combine, or they synapse at different rex lamina. So our main interest is A delta and C fibers. So A delta are in 1 and 5 and C in 2. But there is also other parts in the rex lamina which are attached to things like light touch or which are different fibers, which are heavily myelinated fibers. Now, in neuropathic pain, there is a cross sprouting of these fibers where they attach or sprout and they attach to, say, C fibers or A delta fibers. So the perception or the light touch perception is considered as pain. That is how it is modulated. So that is what allodynia. That is how allodynia happens, and that's how hyperalgesia happens. Also, there is in neuropathic pain, this slight difference is the inflammation. So there is new theory that there is, apart from the inflammation at the periphery, in neuropathic pain you don't see any inflammation in the periphery. What you see is inflammation at the level of spinal cord, at the level of dorsal root ganglia, and that's how the neuropathic pain. So there's actually inflammation around the nerves at the level of spinal cord, which causes this problem. And then the modulation at the level of spinal cord is mainly by two processes. One is descending inhibition, and the other is descending excitation. Descending inhibition, as somebody mentioned, is there are two neurotransmitters, noradrenaline and serotonin, and the excitation is mostly by gabapentin. And then in the brain, again, brain only perceives what spinal cord sends a signal. So if it's neuropathic, it will be perceived as neuropathic pain. Now, I'm sure you still can understand pain completely, and I mean, we do understand some part of the pain, but we still don't understand how things work and how we all going to many different neurotransmitters from spinal cord, brain, and trying to understand how it works. And it is still not apparent how it works. The common causes of neuropathic pain are these. So there are peripheral causes and there are central causes. Peripheral surgical pain. Now, post-surgical pain is not just neuropathic pain, it's nociceptive and neuropathic pain. But there's a major component of neuropathic pain. Then we have post-herpetic neuralgia, CRPS, amputation pain, and then central nervous system pain, central post-stroke pain, which is a really horrible pain and the most difficult pain to come across and be treated. Multiple sclerosis pain, I'm sure you guys know multiple sclerosis. Again, it can cause a lot of neuropathic pain at different sites, can cause single nerve, multiple nerves, central. Spinal cord injury, again, we're aware of that. Epidemiology, now around 8 to 18% of adults, they suffer from neuropathic pain. Most common causes are diabetes, HIV, and post-herpetic neuralgia. Other are CRPS, phantom limb pain, and so on. The risk factors are more common in women, older age, unemployed, and lower education background. Now, these are social factors, and there are certain psychological factors as well. People who are depressed, who are anxious, who've got high hyperactivity, or all those kind of psychological reasons enhance the effect of any type of pain, nociceptive, neuropathic, central, or peripheral. So I'll start with something common. We all know about post-herpes causes. What is varicella? I'm not going to go into those things. What I will go into is post-herpetic neuralgia, which is the pain that persists after the infection is over. Now, it is chronic. It is debilitating pain in the dermatomal distribution that persists after healing of shingles rash. It is very unusual to see post-herpetic neuralgia after initial varicella infection, but it is common to see after reactivation of varicella infection. I don't know why, but this is what's commonly seen. And the incidence increases with age. So as you get older, you get more incidence of post-herpetic neuralgia. They can be classified as acute phase pain, subacute, which is less than, so 4 to 12 weeks, and more than 12 weeks. Pathophysiology, it is quite complex, but I think you can get a question in the exam about this pathophysiology. And this slide is very simple. When you go into the article that's mentioned, the BJ or BJ education article, it is quite complex. So I can obviously share the slide with you guys, but this is what happens. The two main mechanisms are deafferentation and sensitization. So what this virus does is basically deafferent or completely sever the nerves at the region of dorsal root ganglia and the spinal cord, caused by inflammation, mostly because the travel of virus because the virus actually is reactivated at the level of dorsal root ganglia. So it causes degeneration of affected primary afferent neuronal cell bodies, which is dorsal root ganglia, atrophy of the spinal cord at the level of dorsal horn. It causes scarring of dorsal root ganglion, and then eventually, as you all know, that the pain, the cell bodies at the level of dorsal root ganglia, they are unipolar. So they're not exactly unipolar, but because one part of the cell body sends axons to the spinal cord, the other part goes to the periphery. So they're pseudo-unipolar. So when there is a problem at the level of spinal cord, there is a chance of loss of epidermal innervation as well. Again, coming to proposed mechanism, neuronal inflammation, we keep saying this peripheral sensitization and central sensitization. Essentially, there is increase, the area around the peripheral insult which is sensitive is increased. So if you have an injury where like a pinprick, the area around that becomes more sensitive, and a similar thing happens in central sensitization. The problem with central sensitization is not just my spinal cord, the brain also gets involved with it. And as I mentioned, the cross-sprouting, which is the reason of tactile allodynia and hyperalgesia. Now, the postherpetic neuralgia patients are divided into subgroups where they are irritable nociceptors, which is peripheral, deafferentation with allodynia, and deafferentation without allodynia. This is, again, in the exam, it's important to remember because this is asked in the exam. The risk factors, the patient-related are old age females, immunosuppression, disease-related severe prodrome, which is a severe pain during prodrome, which is pain when there is prodrome, a severity of rash and pain during rash, and ophthalmological involvement. Again, psychology is important. Mood-related problems where depression, anxiety, poor coping and stress, there are also risk factors for developing this kind of pain and any kind of pain. Clinical features, non-specific, which is part of prodrome, rash, which is usually unilateral area. It is related to the dermatome. There are descriptors which are important to remember, which is burning, lancinating, sharp, shooting. All these are descriptors of neuropathic pain, which can be in a form of mixed in different kind of neuropathic pains. There are certain descriptors which are specific or not specific, but more common in certain kind of pains, and I'll come to that when we talk about diabetes. Pain can be deep, superficial, continuous, or intermittent, and the intensity can increase during the day, and it can be really bad in the evening. Associated with allodynia, hyperalgesia, or hypoesthesia. Now, it's not just the pain, what it causes later on. Because if you have pain all the time, you can lose a lot of functions. And that is really important when we talk about biopsychosocial mechanisms. So we have to deal with the pain and the other stuff. So once you deal with the pain, the other functions start to come back. And the loss of functions are, you can have weight loss, anorexia, chronic fatigue, decreased physical activity, and sleep disturbances. And obviously your mood and behavior changes. The effects, it's again, this is a multiple choice question. Cervical dome is affected, dermatome is affected in 20%, ophthalmic 20%, and thoracic dermatome, which is the most common, is 50%. Management, all the management in chronic pain is biopsychosocial mechanism. But there are certain things that are added or specific for certain pathologies. So In this, it is important in post-herpetic neuralgia. It is important for you to remember that prevention is very important. Vaccine for primary varicella and antiviral medication. So start the antiviral medication within the first 48 hours can reduce the incidence of post-herpetic neuralgia by 50%. The way I learn or I remember is approach, AGM. Approach is biopsychosocial multidisciplinary approach. When we say multidisciplinary, we actually mean multidisciplinary, which is all the disciplines. Patient education and method can be pharmacological and non-pharmacological. The patient should be referred to specialist services if the pain is severe, health is deteriorated, and the second line agents are not effective, which are essentially, I'll come to the second line agents. NICE guidelines say tramadol as a third line only for acute or emergency service, emergency reasons only. Yeah, another thing important to remember is these patients are elderly. They have got many other medications, so try not to interact with those medications when you prescribe post-neuropathic medications. Diabetic neuropathy. So diabetic neuropathy is the most common long-term complication of the condition. It depends on the duration of diabetes and degree of glycemic control. Prevalence can be around 10% to 53%, depending on the duration of diabetes again. And type 2 is more common than type 1. These are the risk factors, again, exam thing. According to Eurodiabetes, the risk factors are duration, poor glycemic control, hypertension, smoking, raised BMI, and hyperlipidemia. The risk factor for painful diabetes is painful diabetic neuropathy, duration, again, severity of neuropathy, impaired renal function, peripheral vascular disease, and BMI. Classification, the article of diabetic neuropathy in CACCP will tell you this. Most common is chronic sensory motor polyneuropathy, and there are other ones also which can happen or coexist with that. Clinical history gone through by Philippe. This is mainly assessment. Investigations, you can go from anywhere from nerve conduction study, EMG, skin biopsy. Differentials, so exam, they will always ask for differentials. So you have to mention, in the long case, you have to mention alcohol, B12, thyroid, spinal stenosis, HIV, and cancer treatment. Pathophysiology, again, mentioned in that article. Important bits to remember is it's a complex interaction between hyperglycemia-induced metabolic and biochemical changes and inadequate perfusion. Other things are mentioned: polyol pathway, AGE, impaired neurotropic support. These are all, you can mug this, but I mean, it's all very unclear which one is more important than the other. I understand that AGE is very important in these. Again, this is all central and peripheral sensitization. Acute painful neuropathy, it's uncommon, but the good part is that it disappears within 1 year of achieving normal glycemia. So important is to remember is to factor in the blood sugar levels and the way that the glycemic control changes in that person. If it's not very controlled, the chances of neuropathy is increased. Management. This is all recent, so improved glycemic control is more important in patients with type 1. And lifestyle
2 minutes, Manish, so if you can just wrap up the management, is that okay? Because that's important for them, yeah?
Yeah. And lifestyle modification is more important in type 2 diabetes. So pain management, so first line therapy is anticonvulsants, SNRIs, which is selective noradrenaline reuptake inhibitors and tricyclic antidepressants. The difference between tricyclic and SNRIs is tricyclic is non-specific. It is non-specific for noradrenaline and serotonin, and that's why it is tricyclic antidepressants. The way it works is you start one, use it for 6 weeks, make sure it doesn't work after 6 weeks, then you change the other one. If the patient got partial effect, then you start another one. So don't start two together. And if and if it doesn't work, the second line would be to use other medications to come in a minute. HIV neuropathic, again, HIV can cause neuropathic pain. 70% experience pain and 69% have got moderate to severe pain. The causes are neuropathic pain, headache, which are more important, musculoskeletal pain, and GI and gynecological pain. Again, distal sensory motor polyneuropathy is the most common, followed by ATN, which is caused by the medications, and then followed by acute herpes zoster and postherpetic neuralgia. Medications, Yi has gone through medications, but mostly this is these are the four kind of medications that we normally use. Anticonvulsants, antidepressants, analgesics like tramadol, which is partly opioid, topical agents, lignocaine patch, capsaicin cream and patch, and other ketamine, Botox toxin or botulinum toxin A, and cannabinoids. Antidepressants, common ones are tricyclic, SNRI, like duloxetine, which is more commonly used. Other venlafaxine is not very commonly used. SSRI, we don't use it regularly and not recommended by NICE to use it for a neuropathic pain yet. In the tricyclic antidepressants, there are tertiary and secondary means. The difference is the secondary means their side effect profile is low. So if somebody is not tolerating tertiary means, you can start them on secondary means. And then SNRI, as I said, venlafaxine and duloxetine. Key features is dose lower than antidepressant dose. So we don't prescribe an antidepressant dose for chronic pain or neuropathic pain. And that's the evidence-based. Exception is duloxetine, where the doses are essentially the same. Onset of analgesia takes about 7 days and full effect in 1 month. So that you have to counsel the patient or educate the patient that it doesn't work as paracetamol works. You need to wait for about a month before it starts to kick in properly. Tertiary means they have undesirable side effects, which Gia has gone through: sedation, dry mouth, urine retention, and giddiness. Secondary means have got less or better side effect profile. Mode of action, we've discussed. There are a few other mode of actions. They also affect the NMDA receptors and they enhance the action of endogenous opioids, and also works on sodium and calcium channels. This is just a diagram portraying what I was just suggesting, the uptake transporters and noradrenaline uptake reuptake transporters, which are blocked by these. Also, the other receptors that are blocked are muscarinic and histamine receptors, which cause the side effects that TCA causes. Dosage and effectiveness, you start with 10 to 25 milligrams and escalate maximum up to 125 milligrams. That's tricyclic antidepressants. Use at least for 6 to 8 weeks. And then if it doesn't work, you change to the second line. This dose is higher than 75 milligrams once daily at night is often unnecessary and can cause a lot of other side effects. Sleep quality, it does cause sleep, but the poor quality of sleep is poor. These are side effects. Again, he has gone through that, but obviously you can go through this again. It's mainly anticholinergic, antihistaminic, and antiadrenergic. So cautious, avoid using in patients with cardiac conduction abnormality, myocardial infarction, prostate hypertrophy, and narrow angle glaucoma. Especially, this is important for the exam again. Patient with renal impairment, there is no dose reduction is necessary for these patients. Hepatic, sedative effects are more pronounced, so be careful in somebody with liver failure. Patients with depression, again, very dangerous because it leads to overdose. A lot of patients with depression come with overdose of TCAs, and you must have seen the A&E and all that. It reduces the convulsive threshold as well. In elderly patients, start with very, very low dose because it can cause postural hypertension and the risk of falls. Serotonin syndrome, Sadiq went through this. So this is what essentially is. The 4 important things to remember is mental changes, autonomic instability, GI problems, and neuromuscular aberrations. Discontinuation syndrome, so you can't stop any of the chronic pain drugs just next day. You need to make sure you taper it down slowly, all of them, TCAs, SNRIs, gabapentinoids, all very, very slowly because they can cause discontinuation syndrome. Cannabinoids, very likely touch this. This is all new. There are some benefits. Evidence suggests we're not using it as regular medications in pain clinic. It is not recommended to be used in chronic pain yet, but there are some good effects and there are some side effects as well. Just a quick NNT, which we're mentioning Oxford. So TCAs have NNT or number need 3.57, while capsaicin is 8%. So there is a range of NNTs. We just don't look at NNTs. We also look at NNH, which is important in these drugs because they're long-term drugs. So we look at that as well. Again, nice for a person with so these are basically nice guidelines. Offer one, and then consider all the comorbidities and conditions and previous medications and titrate accordingly. Do not prescribe more than one neuropathic at the same time. For a person with localized neuropathic pain who wishes to avoid or cannot tolerate, you can use capsaicin cream. Do not offer any other drug unless advised to do by a specialist. Once it is started, it can be used in primary care. Arrange early follow-ups to assess progress made with dose titration. Advise person on dose titration, so important. Patient education is really important. Considering referring to person specialist pain clinic or relevant specialty clinic if they have severe pain or the pain changes, and that is really important. If the pain is the same, it's fine, but if the pain changes, it could be something else. This is very important for cancer pain, especially because it might suggest cancer spread. If people are awaiting referral, short course of tramadol can work. Any questions, please?
I think that wraps it up. I mean, you've been very thorough, Manish. Thank you very much.